nature of the blood supply to the liver, how it is regulated, what are all the effects of liver failure or decompensation, and so all these questions will be routinely asked. So instead of wasting time, I will just go to show you those presentation where it will be like a question answer type. Okay. So Tanu can try to answer all the questions that is being shown, and if you are not able to answer, others can supplement or they can come to help him. Okay.
Yes, sir.
So I'll my screen with you. Able to see my screen?
Yes, sir.
So this is a very simple one-line case summary or case scenario. 50-year-old patient suffering from alcoholic cirrhosis of liver posted for umbilical hernia repair. Okay. So now, what are the points to be considered in this case? Major points are patient's overall condition. Because when they just say cirrhosis of liver, we do not know what is the degree of involvement of the liver. Whether it is a compensated liver disease or a decompensated, whether it is an end-stage liver disease, nothing we can make out from this one word of cirrhosis of liver.
Yes, sir.
So two important points we have to consider here are, one is patient's overall condition, including the degree of involvement of the liver. Second is the complexity of the hernia repair, whether it is a very simple hernia as I told you, or whether it is a huge hernia. Just for example, you can have a hernia like this, a patient who has a huge ascites, or it can be a hernia like this. Do you think it is easy to operate this hernia under local infiltration?
No, sir.
But there may be a lot of intestine protruding, or it may be incarcerated. So already it is infected, the skin is necrosed. So in such cases, infiltration is not possible. So you can have a hernia from a very simple one to a very complex one. So these two things are to be taken into consideration. One is the patient's overall general condition and the liver involvement. The second is the complexity of the hernia repair. So assess the severity of cirrhosis, patient's overall health, and patient preference. Patient also sometimes may say, I want to be fully asleep, I don't want any injection in my back or in the operative site. So these are the three important things we have to take into consideration. With regard to the hernia repair, nowadays we have a option of doing it under laparoscopic technique. Instead of the open technique, which was practiced in the olden days, we have always a choice of doing it laparoscopically also. So, do you think is it possible to do this under laparoscopy?
It's difficult,
And
sir.
if the surgeon says, I want to do it by laparoscopic technique, he has told the patient also, I will do it under keyhole, will not have a major scar or anything. So how to manage if it is going to be a laparoscopic procedure? What is the challenge?
Challenge is to maintain that hepatic blood flow, sir, during ingestion or during ingestion. We have to.
Okay.
And
else? Abhirami?
let the increased risk of aspiration also, sir, during the intubation. So airway to be secured fast for this
See,
patient.
you look at the
Fourth
picture. I am
position,
asking
sir.
the question, showing you a case in a typical patient picture here. So in this case, is it possible to do a laparoscopic repair of the hernia?
No, sir.
No, sir. The acidic is
Why you can't do that?
Pneumoperitoneum is impossible.
Already fluid is filling the entire abdomen. So how will you, supposing surgeon says, I want to do it only under laparoscopy, how will you proceed with that?
And we have
What is the
to.
first thing?
It is, we have to tap the ascites before surgery, sir.
You have to do a paracentesis and remove the fluid and make the abdomen free from fluid, and then he can go ahead and do laparoscopic surgery also. That is possible. But what are the risks or dangers of doing a paracentesis in this patient?
Hypovolemia.
This may have hypovolemia, sir.
Hypovolemia. Is it a fluid within the circulatory system, or is it an
Hypoproteinemia.
No, sir.
extravascular
This
fluid?
is not an effective.
Hypoproteinemia.
Hypoproteinemia. Then
Sir, that flangic vasodilation, sir, the main reason behind the fasciitis. So that is not an effective circulatory volume, sir. So once we're tapping, the patient went to degradation, sir. Already the patient may be in dehydrated state also, sir.
okay.
So we have to
But
add
this
some
fluid
albumin.
is in the third space. It is not inside
sir.
the vascular compartment.
Yeah, vascular
isn't it?
system, yes, sir. Yes, sir.
So how do you say it will cause hypotension because you are tapping?
Because there is not an the total body water increases, sir, but the effective circulating blood volume is actually reduced in this patient, sir.
Yeah, even otherwise
what
it will be
about
reduced.
sepsis?
Any cirrhosis patient, you
Yes, sir.
expect a reduction in circulating volume.
Yes, sir.
Why?
Because of that abnormal distribution of that fluid, sir. That is flangic
Why
vasodilation.
abnormal distribution?
That,
Portal
What
because of
exactly
hypertension.
happens to the peripheral valve circulation?
yes, sir. Because of
Portal
the portal
hypertension.
Huh?
Portal
That's how
hypertension, sir.
dilatation will be there. Okay.
yes, sir.
So the patient usually, once you tap it at the same time, what is the maximum fluid that you can remove by paracentesis?
2 liters, sir.
This may have more than 2 liters. It may have at least 10 liters.
Yes.
Right, we will come to that later. So this is another option. This is and the surgeon's experience is also very, very important. So whenever they do the repair, you should know how to whether the surgeon can manage it with all the complexities in the patient. So taking these points into consideration, any discussion of a long case or a major case will involve these 20 points which you have to go in an order and present it in an orderly fashion. Okay? So any case discussion should include, first of all, the history. How long the patient has been having it, what is how it started, and what is his alcohol habit, like how much he takes, the amount, how long he has been suffering from that, all that history and complaints and findings. This is what we have to first start with. Then coming to this particular condition, where you say the patient may have a different types of liver cirrhosis. What are all the types? So how to classify the types of liver cirrhosis is know. Then what are the effects of liver cirrhosis on various systems in the body, starting from the cardiovascular, respiratory, renal, GA, etc., CNS, all these things. And then anatomy of liver, blood supply and regulation of blood flow. This is a very, very commonly asked topic. So you must be thorough with that. Then histological importance. What are all the lobules of liver? What is their significance? Then what are the normal physiological functions of a healthy liver? Then if the case history says it is an alcoholic cirrhosis of the liver, they may ask you all the questions about alcohol metabolism and how the consumption of alcohol causes the hepatitis and the cirrhosis. So the pathophysiology of alcoholic hepatitis will be asked. And once a patient has a cirrhosis, the next complication of cirrhosis is development of portal hypertension. So all the questions about how the portal hypertension forms, and then that leads to the formation of ascites and the various complications like hepatic encephalopathy, hepatorenal syndrome, which affects the renal system, and in the respiratory system, you may have hepatopulmonary syndrome or portopulmonary hypertension. And then once all the complications have been discussed, then they always, in any case presentation, after describing these points, you should always do a risk stratification as a first thing. So in this particular case, depending upon the severity of cirrhosis, you have several risk stratification scoring system, and the earliest one is the child report and proof system, CPT scoring or CTT scoring, whichever way you want to call it. And that was the earliest one, taking the parameters like bilirubin, albumin, ascites, nephropathy, and nutrition, etc. And the nutrition then later on substituted by the prothrombin time and INR, which are considered as a marker of liver function. And based on that, we have a classification of class A, class B, and class C, where class A patient is considered with a very minimal involvement of the liver and almost like a normal patient with a very good success rate and without any morbidity or mortality, compared to the class C patient who will be a very high risk patient who is likely to go in for complications or morbidity and mortality. And after the risk stratification, of course, these investigations also should be done, and based on that only you do the risk stratification. And all complicated cases should be optimized as much as possible before you take up the patient. So this is what you have to describe, because you went in that order only. And what are the goals in the anesthetic management? What are all the points you have to keep in mind? And lastly, you should describe about the choice and selection of anesthesia. So this is the order in which we should always discuss any case scenario in the examination. This will make you remember the points that you have to answer also whenever they ask you questions in between, so that you will have a continuous flow of thoughts without struggling to remember the answers the questions are asked. So with that in mind, what are all the important history that you will elicit? I think Tanu described all that. Probably it was from the old video. He made it verbatim. So chronic alcohol consumption.
Sir, I
How
have
much of
two
alcohol
questions, maybe, sir.
patient takes?
First
And,
question is, sir,
how long?
is
keep
routinely
taking?
in our OPD, sir, like if the patient
Whether
and
there was any blood
urine ACR is like
transfusion, IV substance
200,
abuse or
and
tattooing.
most of the time
Even
with
though
urine
we have
ACR,
a
we do that urine
history
RDSS,
of
and the
alcoholism,
first self is 1 plus or 2 plus
they may
plus,
ask
sir.
you
But
what are all
patient
the
is
other
asymptomatic,
causes
there's
or
no
other
burning inflammation, no.
important
And
reasons
sometimes
where
some patients are there
have
like PP is like 400, 500. So in those patients,
Hello,
could you
somebody's
start at Findernon
audio is
or
on.
we wait or do something
So,
else?
Sivatanu, can you mute yourself, please? Sivatanu?
With UTI.
I'm not
So I
speaking,
think
sir.
what I can understand your question is risk of UTI
Shri,
versus starting these drugs, right?
Shri, can you
Sir,
please mute yourself?
that urine ACR is high. So first we go for the sugar control, or if patient is
What is happening?
And you can straight away start them on Finerenone. There is no contraindication to that. My only concern in this patient would be that the dilemma in my mind would be that would I start him on
Presentation is going
SGLT2
on.
or not? Because one, he is having uncontrolled sugars. Second, he has got a little bit of pus cells in the urine.
Her audio is it?
Yes, sir. Yes, sir. I moved her to the lobby. Now we can proceed, sir. Thank you, sir.
Okay.
Sorry for the interruption.
Right. What is this Wernicke-Korsakoff syndrome?
It is due to the vitamin B1 deficiency, sir.
Thiamine deficiency. Yes, it happens in chronic alcohol patients where it causes B1 deficiency or thiamine deficiency. And what is the impact of that? What is the manifestation that it will produce?
Sir,
Confusion.
confusion. During induction,
CNS symptoms.
we got to
Okay, it is mainly CNS symptoms which will cause
Yes, sir.
confusion, ataxia, and eye abnormalities. Okay, it's a neurological syndrome caused by thiamine deficiency. So it is also called as alcohol-induced encephalopathy. Okay, and what is the importance of nutrient lacking in liver disease patients? What will happen if some particular nutrient is not there in liver disease?
Proteins, sir.
It's a free fatty acids. is essential free fatty acids, which is lacking in patients with liver disease, so they want to be supplemented. Now coming to the complaints and physical findings in cirrhosis patients, you have almost all the systems getting affected. So they may come with the general complaints of malaise and fatigue, anorexia, weight loss, feeling of gradual enlargement of the abdomen, swollen legs or abdomen. Sometimes they may have epistaxis or the scratch marks may start bleeding. They may have jaundice, they may have tremors. These are the common complaints which will have to elicit. And physical findings, starting with the skin pigmentation, xanthoma, sort of skin changes because of vascular dilatation, and finger clubbing is also one of the important things. It's a non-cardiac condition. Clubbing can happen in this patient, and they may have caput medusae. What is this caput medusae?
Dilated veins around the umbilicus, sir. Is that
Around
it
the umbilical.
means a portosystemic anastomosis.
Anastomosis, very good. And gynecomastia, why they have gynecomastia?
Because of the increased estrogen, sir, in the patient.
Increased estrogen or decreased testosterone?
Decreased testosterone.
Hmm? It's an hormonal imbalance. That's why testicular atrophy also happens. Okay?
Yes, sir.
So instead of having a normal amount of testosterone, there is a domination because of the even normally men have more testosterone and less estrogen. Here,
Yes, sir.
because the testosterone production is affected, estrogen becomes dominant. That is why all the female characteristics come here, and they will have acromegaly, ascites, etc. And this will be the classical picture. How is this picture described?
Poverty above and
Poverty above and prosperity below. Okay, so that is how it is being described mostly. A classical, in a severe degree of cirrhosis patient will have a picture like this: poverty above and prosperity below. Now, the types of cirrhosis or causes of cirrhosis can be, first we have alcoholic cirrhosis here. What are the other causes?
Non-alcoholic
Fatty liver, okay, hepatitis. Then
primary biliary
Viral
cyst,
hepatitis.
NASH,
viral
NA,
hepatitis.
FLD,
Okay, so post-necrotic cirrhosis,
Wilson disease,
primary and secondary
hemochromatosis,
biliary
Wilson's,
cirrhosis,
primary cirrhosis at
NASH,
Wilson
biliary
disease,
cirrhosis,
hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. So these are all the various etiology or causes or types causing cirrhosis of liver. Now, what are the phases of cirrhosis of liver?
So first fatty liver. The second state
compensated
steatosis,
Compensated
and
and
steatosis,
decompensated. These are the only two
steatosis,
phases. Okay?
fibrosis, compensated cirrhosis,
Those are all
decompensated
serial
cirrhosis.
stages, but ultimately, functionally, it should be called as compensated and decompensated. When
Okay.
will you call it as compensated? When will you call it as decompensated? What is the criteria to say
if
whether
you
a
lab
cirrhosis?
features, it will tell.
Pardon?
The
Lab-
patient had
lab
developed portal
features.
hypertension, sir. The patient had developed a portal hypertension.
Portal hypertension.
Is there a value?
The lab features, sir.
Child book
features.
score,
Serum,
child
bilirubin
book score more than 3A is decompensated, sir.
Which 3
So
years?
serum bilirubin is more than 3, sir. And
Child book score, sir. Child book score.
CPT score 3 more than 3 is decompensated. Not
Yes, sir. Yes, sir.
It's not the criteria. Okay. Parameters which decide this classification are patients with compensated or largely asymptomatic with preserved hepatic function. Okay. So they will have very minimal abnormality, but still they will have some cirrhotic changes if you see the histology. Whereas in the patients who have decompensated, the liver function start reducing, and the major features they will have are ascites, variceal hemorrhage, encephalopathy, or jaundice. So any one of these when it is present, it is called a decompensated liver disease, and in those patients, the total pressures also start going up. Okay. Now, what are the changes that happen in the various systems in patients with the decompensated liver cirrhosis or the liver disease? For that, this is the mnemonic I normally remember to describe the various systems. Can you just expand this acronym and say what are all the systems that are given here?
Cardiovascular system.
Cardiovascular system. So first thing is cardiovascular system. What are all the changes that happen are decrease in SVR, increase in cardiac output, which results in hyperdynamic circulation. Okay. What is the next thing? H.
Hematology.
Hematology. What are all the changes that will happen in hematology?
Coagulopathy.
Anemia, and this thrombocytopenia, coagulation factors.
Coagulation
The coagulation factors deficiency.
Hematology, mainly anemia and coagulopathy.
coagulopathy.
Right. What does the I stand for?
Immune system.
Immunity. Okay. Immune deficiency. So decreased immunity, spontaneous peritoneal active peritonitis. We see occurrence of sepsis in these patients. What is the E for?
Esophageal varices.
Esophageal varices.
Endocrine, sir.
Electrolyte disturbances. Okay. And R for fluids. They can have both hypo and hypervolume status. What is the R stand for?
Renal
Renal,
and
sir, renal
respiratory
system.
Renal
Renal
and respiratory.
Respiratory
Both you
system.
can have. Okay. Respiratory, you can have the PSPOH, orthodeoxia, pulmonary hypertension. And with regard to the renal, you have hepatorenal syndrome, which is the most important complication. And with regard to A,
Acid base state, sir.
acid base and albumin.
And
So, respiratory or metabolic alkalosis is more common, and there is a decrease in the albumin production. And what about N?
nutrition.
Nutrition. So nutrition lack lead to due to anorexia or impaired absorption. And what is the G standing for?
Glucose and GIT system.
GI and glucose. Esophageal varices, nausea, jaundice, hypoglycemia. So the varices comes only under GI, not separately as you formed the earlier said. And the other E stands for
Encephalopathy.
carpet tremors. And the last S stands for
Skin.
skin changes like pruritus, petechial hemorrhage, etc. Okay, so these are the 11 things. If you can remember, it is very easy to describe whatever they ask you about the various involvement in the systems. The next question is, what is the anatomy of the liver, which can be asked routinely. So how do you describe the anatomy of the liver?
Liver is situated in the right
Hypochondrium.
hypochondrium, sir.
It has
Straight
8
away,
coinoid
start
segments.
saying
It
how
has
many
the
Right,
largest
two
gland in
lobes.
the body.
largest gland in the body. What is the
It
weight?
has weight is 1,200 to 1,600 grams. It has a wedge shaped, and it has a 20%
Capsule.
of the cardiac
Covered by
output.
rice and
It is
capsule.
connected by. It is
The
connected to the
largest gland with a weight of 1,200 to 1,600. It is covered by a network of connective tissue called Glissen's capsule.
Capsule.
And how many lobes are there?
There are two
two
lobes,
lobes,
right lobe
left
and
lobe.
left
Large
lobe,
right
separated
lobe
by
and a small
IVC.
left lobe. Okay, it has a large right lobe and a small left lobe. And right lobe, does it have any subdivisions?
Coinoid segments,
Sir.
sir. There are
So
6
eight,
coinoid
sir.
segments.
It's a caudate and quadrate
Quadrate
lobe.
lobes.
The right lobe has got two minor lobes called caudate and quadrate lobe. So totally, if you think right lobe has got these two extra, means there will be 3 on the right and just a single on the left. So totally 4 lobes we can say. So this is how the whole thing looks like. Okay, from the
And 5
anterior and
ligaments.
posterior view. And these are all the relationships. The gallbladder, the bile duct, everything is all under the upper surface of the liver. And what are all the ligaments of liver and what is their function?
Falciform, there are 5
Falciform
ligaments.
ligament.
Falciform ligament separates right and left lobe of the liver, and right and left triangular ligaments, and coronary ligament, and a round ligament, which is the remnant of right umbilical vein.
Okay, what is their function? Of course, falciform you said can help to differentiate the right and left. What is the function of the other ligaments?
They're connected to the diaphragm and abdominal
Diaphragm and abdominal wall. Very good.
To
So there are
maintain the
5
position of
ligaments:
the liver.
falciform, coronary, right and left triangular ligament, and round ligament. And their main function is they connect it to the diaphragm and the abdominal wall.
Abdomen.
And falciform ligament separates the right and left lobe. What is calcification and how it is used?
It has
Even though it is
it has
written as
8
COUA,
segments.
8 independent segments.
8
independent
independent segments. 2 segments on the left lobe and 6 segments in the right lobe.
Every segment has
First
its
of
own
all, what is
independence.
this classification?
Functional segmental or functional classification of the liver.
So based on the vascular supply, this French person called Quino, he divided the liver into individual segments with their own blood supply and the biliary system, so that you can remove that segment alone in case you want to transplant, or you can do a partial hepatectomy using that landmark. So this is the classification by a French person called Quino, and they used to describe the functional liver anatomy. So this is a structural liver anatomy, this is a functional liver anatomy, and it is a preferred anatomic classification. It divides the liver into 8 independent functional units, and rather than morphological description. And it has got, each segment has got its own dual vascular supply. What is the dual vascular supply to the liver?
Hepatic artery and
Hepatic
portal
artery and
Hepatic artery and
vein.
portal vein.
75%.
It has a biliary drainage, lymph drainage, and helps in doing partial or segmental hepatectomy in live donor transplantation. It is the main importance of this particular classification. So that may be asked in the exam. Now coming to the important point of blood supply to the liver, how is it different from other organs?
because it has dual blood supply.
Yeah.
Predominantly 75% by the portal vein and 25% from the hepatic artery, and it has it's a hepatic artery buffer system also, sir, to regulate the blood flow.
That is the regulation. Okay?
Regulation.
So the main thing what you have to say is it is a dual supply.
Dual blood supply.
What is the purpose of this portal supply? 75% of blood being supplied by the portal system. Why?
Reservoir.
Reservoir.
For the sinusoids.
What does the portal blood contain?
The portal blood contains the deoxygenated blood.
Oxidation is less, but what is the major constituent of
The portal vein.
The portal vein carries that all the metabolites
the
to the
nutrients
from the
from the
abdominal organs
intestinal
to
tract.
the
Okay, whatever food
liver.
you are eating, that is all absorbed through this system, brought to the liver for metabolism. Okay,
through
so
portal
all
vein.
the nutrients that have been ingested are brought to the liver by the portal vein. That is the main function of that portal vein which is coming there. So you call it as vein. It is mainly to carry the nutrients from the intestinal tract. And hepatic artery supplying only 25% is mainly for supplying the oxygen required to the liver function. Okay, so that is the importance of this. So it's a dual blood supply by hepatic artery, hepatic portal vein. Why you call it as hepatic portal vein? Why you can't you just say it is a portal vein? Why should you always add that adjective of hepatic portal vein to that? Do you have any other portal system?
Yes, sir. Pituitary.
Pituitary you have.
Pituitary,
Okay, so there is a pituitary portal venous system also is there, which brings the hormones produced from the hypothalamus to the pituitary first storage. Okay, that is the pituitary portal system, and that is the reason why anatomy books they always distinguish between the hepatic portal system and the pituitary portal system. There are two portal systems. So it receives about 25 to 30% of total cardiac output. That means what is the blood supply? How much of blood supply it comes?
Sir,
1350 ml.
0.5 liters.
1500.
Out of 5 liters, 25% is 1.25 liters. Isn't it? So from
Yes, sir.
1.5 to 1.25 to 1.5 liters of blood is flowing every minute to the liver, of which 75% with oxygen saturation of 80% from the portal vein. The rest of the 25% supply with an oxygen saturation of 99% is from hepatic artery. And how much of blood the liver sinusoids hold? They can
300
hold
to 500
400 to 600 ml of mixed blood, which will be a combination of both a arterial and pulmonary venous blood. What is the importance of this liver sinusoid capacity?
While it will give the blood reservoir for while hypotension.
This is the reservoir actually. Okay, this one can squeeze and immediately push all this blood into the systemic circulation. If you have a injury and hemorrhage, if there is a blood loss in any normal individual, this is the blood which will come to the systemic circulation to replace that loss and prevent hypotension happening or hypovolemia happening in the patient. That is the reason why there is so much of blood in that. And what is the nature of liver sinusoids? What is the classical anatomical description about the liver sinusoids?
Hexagonal strips.
Hexagonal space.
It will macrophage.
Triad of
Macrophage.
biliary duct, portal vein, and hepatic
That is
branch of
portal
hepatic.
triad. That is
Yes.
not liver sinusoids. What are you talking about?
It has
It
cytosol
protects from the
and stellate
toxins. Sir.
cells.
It protects from the toxins from macrophages.
Is it like a normal vascular capillary or anything, or is it a different structure?
It's a
It has
penetrated
Kupffer
endothelium.
cells.
Space between the
It is a distensible vascular channel. This is the classic description of liver sinusoids. It's a distensible vascular channel lined with highly fenestrated endothelial cells and surrounded by hepatocytes. Just outside the sinusoids, you have the hepatocytes arranged in a linear fashion. Okay? So the nature, this distensible nature only makes it to accommodate and hold the blood, and if necessary, squeeze it and pump it into your systemic circulation. So this is a distensible vascular channel. And this fenestration, why it is so highly fenestrated endothelial lining is there?
you can remove the toxins. Sir.
Toxin by fenestration. வீட்டில் போய் சல்லடை போட்டு சலிக்கிற மாதிரி நினைச்சீங்களா? Toxins are removed by Kupffer cells. What will happen if you have a lot of gap in between the cells? What will happen to the blood?
Leaky.
Blood will flow
It
to
will
the
leak and go towards
Go
the
to-
hepatocytes which are surrounding it.
oxygenation, sir. Temperature.
Okay, so is there a gap between this endothelial lining and the hepatocytes, or they are all adjacent to close to each other?
Adjacent to each other, sir.
There is a space. What is the name for that space?
Space of
of-
exhale.
Space of Dissy.
To see.
There is a space. How can it be adjacent? Of course, they are adjacent microscopically, but then there is a small gap. So the blood that is present in the sinusoid, they leak through this, fill up that the Dissy space of Dissy, and then only reach the hepatocytes. Okay, so that is how the supply of blood and nutrition by the hepatocytes is done in the sinusoids. And the blood leaves the sinusoids via the central vein, which drains ultimately into the hepatic vein. And they have Kupffer cells, which are nothing but specialized macrophages, and they only guard against bacterial invasion or toxins. And this picture will nicely tell you about that. Okay, so you can see this is a sinusoid. Okay, this is a sinusoid. This is a sinusoid. This is a sinusoid. And this classical sinusoid, if you see, this is the hepatic arterial oxygenated blood coming here, and this is the partially deoxygenated portal blood coming here, both mixed here. It is filling up this sinusoid. And you can see these are all the hepatocytes, which are all adjacent to that. And this is the fenestrated endothelium. And if you make a little larger enlargement, you will find there will be a small gap between the hepatocytes, which are lined are here, and the endothelium, which is called the space of disease. Okay? And ultimately, all this blood will drain into the central vein, and this central vein combinedly will go towards the central hepatic vein, and then the venous drainage of the whole system will happen. Okay? And once the hepatocytes form the bile, they also seep into that and then enter this biliary canaliculi and then go and drain into the bile duct, which ultimately from individual segments combine to form the intrahepatic bile duct, right and left, and then common bile duct, and then come out, join the cystic duct, and then go to the duodenum. Okay, so these are all the various things, and this picture I think will give you a good idea about the sinusoid, which is a distensible vascular channel. Now, what are the types of receptors that you have in the portal vein and hepatic artery, and why it is important to know that?
Sir, portal vein is a alpha 1 receptor, sir.
Alpha 1 adrenergic receptor, very good. Then
hepatic artery, alpha 1, beta 1, and beta 2, sir.
Yes, so we have, why this difference is there?
Because they give the beta blockers, sir, to the portal hypertension. Vascular constriction to this action, sir. That unopposed alpha action, so vascular constriction, thereby reduce the portal pressure, sir.
But it doesn't have any significance in normal blood supply. First of all, you should talk about the normal why nature has provided like this, with only alpha receptors in portal vein and both alpha and beta receptors in hepatic artery. Then go to pathology where you give beta blockers and their effects. So, what is the physiological significance of this? The hepatic artery carrying oxygenated blood from the aorta has both alpha and beta receptors to fine tune the blood flow to the liver. Okay, that is agreed. And portal vein carrying nutrient-rich blood from the digestive system primarily relies on alpha receptor for its regulation. This type of adrenergic receptor distribution is important for the hepatic arterial buffer response. That is a normal natural response. Okay, so only if the hepatic artery has both the alpha and beta receptors, it can dilate and allow more blood to go when there is a drop in portal venous pressure. But portal vein cannot do that. Vice versa cannot happen. No, it is a one-way adjustment. So that is the reason why you have these receptors situated like this. And of course, you make use of that by giving beta blockers to control when the pathological condition of portal vein venous hypertension happens. Okay? But the natural normal mechanism or physiological reason for this part of distribution is to maintain this normal hepatic or arterial buffer response. Now, how is the blood supply to the liver regulated? What are the factors regulating the liver blood flow? This is a very commonly asked question in the exam, as well as sometimes you may get a theory question also. Control of blood flow to the liver. Factors controlling or regulating liver blood.
Sir, interesting auto regulation, sir.
You have intrinsic and extrinsic factors. That is how you classify.
Sympathetic system activation, sir.
So that's a very gross answer. So blood flow regulation, you can divide it into intrinsic regulation and extrinsic regulation. Under intrinsic, you have three methods. The major method is called the hepatic arterial buffer response, HABR. That is the first and foremost mechanism. Then you have what is called pressure flow autoregulation. Then there is a metabolic control. All these three come under what is called the intrinsic regulation. Extrinsic regulation, you have a neural control and you have a humoral control. So totally you have to write or know about these 5 methods of control of or factors regulating the blood flow. Now individually seeing the hepatic arterial buffer response, what happens? Already we have seen.
Yes, sir.
So can you describe this hepatic arterial buffer response? What are the changes that happen? Supposing there is a drop in portal venous pressure and blood
Hepatic
supply.
artery, sir. Hepatic artery dilates and more blood to that liver, sir. Going to liver.
Instead of the 25% contribution, how much increase it can do? How many maximum increase in the hepatic arterial blood supply? How much it can increase to? Normally, we said 75% from portal vein and 25% from hepatic artery. Supposing the portal blood supply from 75% drops to say 40%, how much maximum hepatic artery can substitute or contribute at that time?
50%.
40 to 50%. It can double almost. Okay, from 25% it can go up to 50%. And that is how the blood supply to the liver will be maintained. What is the factor or the mechanism by which this increase in the blood flow happens? Is it because of nervous control or any other chemical control?
Chemical control, washout of adenosine, sir.
Adenosine, very good. Where else will adenosine produce vasodilatation?
In
the coronary.
Coronaries, very good. When there is a metabolic demand because of exercise or fear or fright, adenosine will improve the vasodilatation. Where will adenosine cause vasoconstriction? Which organ?
PTPH.
Only one organ where adenosine can cause vasoconstriction instead of vasodilatation.
Lungs, sir. Wrong.
That's on the vasculature. Think over it and let us see in the end of the class whether you can answer. HABR changes mechanisms. Synthesis is from washout of adenosine from the periportal regions, and factors which can affect this are endotoxinemia, chronic hypoperfusion may decrease or even abolish this, render liver more vulnerable to hypoxic injury. So that is why patients in sepsis they go in for acute liver failure because of this particular problem. What is the role of autoregulation? Does the portal system have a regular autoregulation like your kidney
No, sir.
or your other organs, brain?
No, sir.
So how is the autoregulation playing a role in maintaining the blood supply?
Hepatic pressure flow autoregulation.
Hepatic artery has some flow autoregulation because it has both the alpha and beta. That's another reason. During postprandial times, okay, after a good meal, hepatic artery can have some amount of autoregulation. But portal vein does not have any autoregulation at all. There is no autoregulation. So drop in systemic pressure will result in decreased portal venous blood flow also. It cannot adjust the flow. That is the reason why hepatic arterial buffer response comes into play. So this is about the autoregulation. Metabolic control. What is the metabolic control? Intrinsic regulation. Supposing you take a hearty meal, then all that meal has to be absorbed and then digested and metabolized only in the liver. Okay. So naturally,
Yes, sir.
that has to improve. But other factors like hypoxia, acidosis, hypercarbia, they increase the hepatic arterial blood flow. Whereas postprandial hyperosmolarity also increases both hepatic arterial blood flow as well as pulmonary venous blood flow. So that is why after your meal, postprandial somnolence or sleepy nature. In the afternoon classes, after your lunch, when you go and sit and hear the boring lecture like this, you naturally start feeling sleepy because more blood flows to the liver rather than to your brain. Okay? And what is the sympathetic and parasympathetic supply and their effects?
Vegas.
Not
What is the segmental supply of which segment of the spinal system, spinal nervous system supply to liver?
T7 to T12.
T6 to
T6 to
6 to
T11. Okay, so postganglionic fibers of T6 to T11 supply the sympathetic. Parasympathetic is from the vagus and phrenic nerve. And increase in sympathetic tone will cause translocation of blood from splanchnic reservoir to central circulation. That is why when you have a hemorrhage, naturally there will be a sympathetic stimulation, and this sympathetic stimulation only causes this translocation from the sinusoids, which hold about 400 to 600 ml of blood to the central circulation in the initial stages to prevent any hypovolemia and hypotension. Vagal stimulation causes redistribution within the liver, intrahepatic blood flow without changing the total blood flow. It will redistribute the blood to within this liver. What hormones have effect on the blood flow? This is the neural control. This is the extrinsic factors. Second extrinsic
Catecholamines.
factor is the hormone.
catecholamines, glucagons, gastrins.
There are so many things: gastrin, glucagon, secretin, bile salts, angiotensin II, vasopressin, catecholamines, cytokines, interleukins, other inflammatory mediators. All of them have been implicated to cause increase or decrease in the blood sugar. They affect. What exactly happens, we do not know. It depends on the situation. But you just remember all the names of these hormones, at least a few of them. So blood supply, you have to remember there is an intrinsic factor regulation, extrinsic factor. The intrinsic, you have the hepatic arterial buffer response, you have the autoflow regulation, and the third is the metabolic control. Under extrinsic, you have the neuronal control, you have the hormone control. But here the sympathetic control is the only thing that can alter definitely the translocation. Otherwise, the major factor is the HABR, which you have to remember. And enumerate the factors increasing and decreasing their blood flow. You can say that clinical conditions: hypercapnia, acute hepatitis, supine posture, food intake, beta agonist, and phenobarbital enzyme inducers. All these things cause increasing blood flow. Factors decreasing are IPPV, hypocapnia, hypoxia, protracted hypoxia, cirrhosis, alpha stimulation, beta blocker, halothane, and vasopressin. All these things decrease the blood. What are the different lobules described by histology and their importance? This is a very
Classic
common
lobule.
you have to know.
Portal lobule, portal acids.
We have three lobules: classic lobule, portal lobule, the third is called portal acinus. Okay, so this picture will tell you there is a classic hepatic lobule, there is a portal lobule, then there is a portal acinus. This is actually not present like this, but it is a imaginary description to understand the function of the liver. Okay, so what is the importance of this classic lobule? It helps in the understanding the direction of blood flow from the portal triad towards the central vein, which ultimately drains into the hepatic vein. So if you see this picture, this is the first classical lobule, which is a hexagonal lobule, and the center part of is the central vein, which ultimately will drain into the hepatic vein. And each corner of this hexagonal, you have the portal triad with a branch of hepatic artery, portal vein, and the biliary duct. Okay, so the blood from the hepatic artery and portal vein will flow through the sinusoids, surrounded by the hepatocytes towards the central vein. So this is mainly to describe the blood flow direction. The second one, which is called the portal lobule, is connecting the three adjacent central veins to make a triangular structure. This is again another imaginary description. So here the center portion, instead of the central vein here, one portal triad will become the center of point. And all the bile that is formed by the hepatocytes will drain into the biliary tract here and then join the major biliary duct. So intrahepatic biliary tree will be formed from here. So that is the reason why you have this portal lobule. So drainage of bile from hepatocytes to bile duct is the reason for this imaginary description. The third one is a very important description to understand the enzymatic functions and metabolic functions of the liver. And for that you have a description called portal acinus, which is more or less like a diamond shaped imagination, where you have two portal triads connected towards the central vein, which with a blood supply of different oxygenated blood supply of different category. So you have description of three zones here. The zone 1, which is very close to this portal triad, will receive the maximum oxygenated blood. The zone 2 will get little lesser oxygenated blood, and zone 3 will get the least oxygenated blood. So based on the availability, the zone 1 will be mostly metabolizing all your nutrients like carbohydrates, fat, and proteins, which require more energy. And less will happen in the second and third. And the third, what is the most important? Why should we know about zone 3?
Because the cytochrome P450 did all
the enzyme cytochrome P450, which is the major enzymatic activity which is present there, is the one which metabolizes most of our anesthetic drugs also, as well as the other drug agents. Okay, so portal acinus describes the oxygenated blood supply to the hepatocyte for metabolic and enzymatic activity. So, what are the names to this portal zones based on the proximity to the portal triad? What is zone 1 called? What is zone 2 called? And what is zone 3 called?
Zone 1 is periportal, zone 3 is centrilobular,
Lobular.
2 is medial lobular.
Middle lobe. Okay. Zone 1 periportal, mediolobular, zone 3 is centrilobular because it goes towards the central vein. It's called centrilobule. Lobule of the liver is very close to the central vein. The intermediate zone 2 is the mediolobular, and this is very close to the portal triad, so it is called the periportal. What are the functions of these zones? Already we have seen highest oxygen supply, so immediate metabolism of all the nutrients plus protein synthesis. Zone 2, comparatively less oxygen, so intermediate enzymatic activity like your reduction class 1 and class 2 enzymatic activities are happening there. And zone 3, the lowest oxygen supply, high in cytochrome P450 activity. And that is the reason why if there is a hypoxia, this zone will be the first one to get affected. And that is why your drug metabolism gets very much affected. And even the normal dosage of drug will act for a long time or produce a toxic effect. And that is the reason why we have to think about this physiological disposition of the hepatocytes and the hepatocyte anatomy. The next thing is, what are the physiological functions of the liver? That is another common question the examiners may ask you. So these are the 6 things you must remember: glucose homeostasis, protein metabolism, fat metabolism, detoxification of the drugs, albumin production, and bilirubin formation and excretion. Now, how does liver help in glucose homeostasis? Very basic question.
Yes, sir. By hepatic glucose production, sir, if the glucose is low,
Glucose produced in the
gluconeogenesis and
liver, hepatic glucose production. Does it produce the glucose?
No, sir. Two gluconeogenesis and glycogenolysis.
That is only a supplement thing.
Yes, sir.
Glucose, what we have in our body is mainly from our food intake, isn't it?
Yes, sir.
So whenever you take adequate glucose needed for your normal day-to-day activity, it is used up by the help of insulin. It goes into every tissue and all the glucose is utilized. In case you have excess glucose more than what is required, then it is converted into
Glycogen.
storage
Glycogen.
glycogen. That is the main function. Okay, excess glucose not utilized by cell is converted and stored in liver as glycogen, and this glycogen can be broken at any time whenever there is a need for or a reduction. Supposing you are starving, you are posted in a liver transplant surgery case. You enter the theater after breakfast at 9 o'clock. It goes on till night 10 o'clock. You have not had time to eat anything. At the time, this glycogen only comes to help you to maintain your blood sugar. Otherwise, everybody will become hypoglycemic, isn't it? So it can be converted to glucose to maintain normal levels because of this particular action. That is the first and foremost important function in maintaining glucose homeostasis. And in case this storage is also exhausted as you go for a starving or fasting protest, Gandhiji did it, they say, for 21 days, 30 days, and all that. So at that time, what will happen? All your glycogen storage will be exhausted. Then body has to form new glucose. So that is where gluconeogenesis or neoglucogenesis comes as a metabolic pathway, where glucose is manufactured or produced from non carbohydrate precursors like pyruvate, lactate, glycerol, amino acids, etc. And this is done not only in the liver but also in the kidney to maintain your homeostasis. What is the role of liver in fat metabolism?
Synthesis and storage of fatty
Synthesis
acids.
and storage, very good. In the liver, all the fatty acids are synthesized and stored in liver, and lipoproteins and cholesterol synthesis also takes place in the liver. It is very important for cell wall formation. And beta oxidation of fatty acids produces acetyl-CoA and ketones happen in the liver. So, do ketones have a role in your normal physiology?
No, sir. Only when blood glucose is extremely low
Hmm.
and when ketoacidosis happens.
Okay. So, what does it do at the time? Which particular
At that time,
organ utilizes the ketone
Brain,
for
brain,
energy
sir.
purpose?
brain,
Brain.
sir.
Okay, so that
Brain.
is the importance of
Brain.
the
But liver
Okay.
cannot utilize the ketones
But
because
if
it does
this
not contain the enzyme.
this
Thiophosphatase.
ketone is in excess, what will happen?
Ketoacidosis, sir.
Ketoacidosis. That will happen in diabetic ketoacidosis. Okay. So how important is the blood reservoir function of the liver? That already we have. So 10% of total blood volume is stored in liver sinusoids. That is 400% centered, roughly 500 ml. And this volume can be transferred to systemic circulation by sympathetic stimulation. How liver products affect cardiovascular system in the body? Especially one particular
Bilirubin, sir.
Bradycardia.
bilirubin. Yes, what does bilirubin do?
Bradycardia.
Normally, it
Produce
will lead to
bradycardia, then
if it is failure, it will lead to tachycardia.
so bradycardia to the suppression of SA node, decrease contractility because vasodilatation, decrease response to beta agonist. Okay? So all these things can be caused by bilirubin. That is why in severe jaundice, patients usually have a bradycardia. And instead of having bradycardia, if they have tachycardia, that means they are already in heart failure because of the reduced contractility. Where overcoming the suppression of the SA node, heart tries to pump more to maintain the cardiac output. So tachycardia in a very deeply jaundiced patient is a very ominous sign that he is in severe cardiac failure. The prognosis is very poor. And this can cause hypotension, exaggerated response to blood loss, and even perioperative shock also. Okay, that is the reason why jaundice patients you have to be more careful. What is the role of liver in protein metabolism?
Almost all amino acids are produced in the liver, sir.
Deamination of all amino acids take place in the liver.
Consummation and
Formation of urea
deamination, sir.
from
Formation of urea from ammonia. Very, very
Urea and
important
uric acid
function.
also.
So what is this
Formation of uric
cycle
acid.
called?
Urea
Krebs
cycle.
cycle.
Krebs cycle.
Uric
இல்ல,
cycle.
Krebs cycle வந்து TCA cycle.
So
This
the
urea
urea
cycle.
Urea
Urea
cycle.
cycle.
And all the
And also
coagulation
blood
factors,
coagulation factors.
these three are produced there. And synthesis of albumin happens only in the liver. That is why it is used as a marker for liver dysfunction. Whenever there is a severe liver dysfunction, you find the albumin levels drop. But this is not an acute marker. Why?
Because the half-life
half-life is
After
21 days.
So only after 21 days and all the storage has been exhausted, then only it will start dropping. So which is a more acute marker?
PTL
coagulation.
INR is considered as a more acute marker to assess the degree of liver damage. What are the other plasma proteins made in the liver other than this albumin and
Globulin.
thrombopoietin.
all clotting factors except these three? Transport carrier proteins like transferrin, haptoglobin, ceruloplasmin, complements CRP hormones like IGF, thrombopoietin, and hepcidin, and protease inhibitors like alpha-1 antitrypsin, alpha-2 antiplasmin, and antithrombin 3. These are all the other plasma proteins. What is the relationship between heart disease and liver disease? Are they interconnected?
Yes, sir.
Yes,
How?
that myopathy, sir.
Cirrhotic cardiomyopathy can happen. Okay. But what about which heart disease can produce affection in the liver?
Right heart disease, sir.
Right heart failure. Okay. So
Yes, sir.
serious conditions like congestive hepatopathy, valvular heart disease, cardiomyopathy, left ventricular failure, constrictive pericarditis, cardiogenic ischemic hepatitis, all causing decreased cardiac output, can produce decreased liver function. Whereas hepatic conditions like cirrhotic cardiomyopathy, portal hypertension, portal systemic shunt, decreased beta adrenergic response, non-alcoholic fatty liver disease, oxidative stress, all these things can affect the heart and produce a. So both are interconnected with it. Heart disease can lead to liver failure, and liver failure can compound or aggravate a heart. How the immune system is affected in liver cirrhosis?
Because of the immunoglobulins,
Super cells can be affected.
Super cells, that you mean the
And in fact,
macrophages.
The
T-cell
globulins are produced in the liver.
T cell product. So reticular endothelial cell, first Kupffer cell function is affected, T cell proliferation affected, neutrophil movement is affected, decreased neutrophil, decreased bacterial phagocytosis. These four things cause a reduction in the immune system, and that is why these patients develop spontaneous bacterial peritonitis without an extraneous infection. This can lead to sepsis, the absence of bile in the intestine, endotoxins will enter the bloodstream, and that is the reason or mechanism by which sepsis is common in liver failure. What are the factors affecting coagulation the liver disease? What are the various abnormalities of coagulation that can happen in liver disease? It always
Both
bleeding.
hypo and
Clotting factors
hypovolemia
due to
affects.
synthesis of clotting
It can
factors.
produce bleeding or bleeding disorder or thrombotic disorder. Both are possible. How is it possible? How can same organ can
Because
produce?
Liver produce both
Procoagulant and
And very good. Produces both procoagulant and anticoagulant factors. So decreased synthesis of clotting factors, prolongation of prothrombin time. This will lead to bleeding. Decreased vitamin K absorption, effective gamma carboxylation, leading to bleeding. Endotoxin absorption, hypersplenism, reducing the thrombocyte content, that will also cause bleeding. Endotoxins cause increased fibrinolysis, low-grade TAC-like picture, again bleeding. And hypocalcemia, again bleeding. Decreased production of antithrombotic factors like protein CS and antithrombin T. This will lead to thrombus formation. Okay, this sixth factor, decreased production of antithrombotic factors, where blood being kept as in the fluid state by protein C, S, and antithrombin 3. This will lead to thrombus formation. So all the other conditions will lead to bleeding. What is the pressure flow relationship between portal venule and hepatic arteriole, normal patient as well as in portal hypertension? We saw in the earlier slide that from the portal triad at each corner of that hexagonal arrangement, you have the hepatic artery and portal vein, and I showed you the picture of the sinusoid where both the blood go and merge and supply into the sinusoids. Okay, so how that flow is controlled? So this picture will tell you. When there is a terminal hepatic arteriole, the pressure in the arteriole, naturally the artery is 35 millimeters of mercury. Whereas the portal vein is a component of the portal triad, pressure is only 9 millimeters of mercury. And at the starting point from the portal triad, where they go towards the hepatic sinusoid and the central vein, there is a sphincter, arteriolar portal sphincter, and this is the mechanism by which whenever the blood flow increases in the hepatic artery, part of it will flow through the portal system also to supply the blood. There is a decreased flow in the portal venous system, and there is a, before they forms the sinusoid here, there is a anterior sinusoidal sphincter on the hepatic arterial side. There is no sphincter on the portal venous side, as you see here. Okay? So this sphincter also controls the blood flow here. And at the sinusoid level, the pressure from 35 and 9 drops to 2 and 3. And at the terminal hepatic venules, it becomes 5 and 10. There is a control sphincter here also before the sinusoid joins the hepatic vein. So what will happen? Early stages of portal hypertension, there will be initial increase in hepatic arterial blood flow and pressure. But later, as the portal hypertension worsens, that the pressure in here increases, what will happen? The hepatic arterial pressure will decrease. Because it cannot overcome this pressure, it will decrease. And the increase in portal venous pressure is due to the increase in the resistance. Okay? So that is how the change. And once the portal pressure starts increasing beyond the hepatic arterial pressure, this hepatic arterial buffer response will fail. That is the reason why acute liver failure can happen whenever there is a systemic drop in the blood pressure. That is the reason why you have to understand this relationship between the portal venule and the hepatic arteriole at the before the formation of the sinusoid and the drainage. And coming to the alcohol is free in cirrhosis, you have the possibility of asking all about alcohol metabolism, and the main organ to metabolize the alcohol consumed is by the liver. So how is alcohol metabolized by the liver?
Alcohol dehydrogenase.
and aldehyde dehydrogenase. Aldehyde dehydrogenase in mitochondria, alcohol dehydrogenase in the cytoplasm.
Cytoplasm. That's the only one?
No, sir, it's accessory pathways also there, sir, major pathway.
So
And
you
minor
have to first classify that into oxidative pathway and non-oxidative pathway. Enzymes involved are alcohol dehydrogenase, aldehyde dehydrogenase, cytochrome P2E1 and catalase. These are the four enzymes involved, but the pathways are divided into oxidative pathway and non-oxidative pathway. So in the oxidative pathway only you have that uh, why some people are able to tolerate huge quantity of alcohol and still be very sane and able to move about, and some people even with a small lesser quantity of alcohol become tipsy and drowsy. All that is determined by the enzymes which are produced by variations in the genes. So the alcohol consumption, alcohol related damage to the liver or the other tissues, alcohol dependence are all decided by the genes which produce these enzymes. And the oxidative pathway is what you described as the alcohol dehydrogenase and aldehyde dehydrogenase enzymes which act on the cytoplasm as well as in the mitochondrial level in the hepatocytes. But the non-oxidative pathways are where these other substances are produced, like fatty acids, phosphatidylcholine, plus glucuronidation with glucuronic acid, producing ethyl glucuronide and ethyl sulfate. These are all non-oxidative pathway products. So four byproducts are there, but here ultimately it is the acetate that is formed, which goes into the circulation by oxidative pathway. So the ultimate metabolic product after metabolization of alcohol results in the production of acetate by oxidative pathway, which happens in the hepatocyte, both cytoplasm as well as at the mitochondrial level. And the non-oxidative pathway produces four other different byproducts or metabolic products by non-oxidative pathway. Okay. So, and these are all, this aldehyde which is produced is responsible for the reactive oxidation species and the inflammatory nature of the alcohol is caused by this particular acetaldehyde. And this acetaldehyde is also been attributed to one other bad effect of alcohol is the hangover effect that happens in the next morning after consuming heavy dose of alcohol is mainly because of this acetaldehyde which is produced. So lipid accumulation, this only gradually will lead to inflammation, constant inflammation will lead to healing by fibrosis. That we will again see in the next slide. So the products of non-oxidative pathway are these four. Is there any significance about this? What should you know about this? We normally talk about this particular step taking place in the society. But what is the significance of this non-oxidative pathway and the products that are produced by that? They can be used as direct biomarkers because it is the enzymatic pathway through which this is happening. These byproducts, if you can assess them in the blood, that will be indication for direct biomarkers. What are all the indirect markers of ethanol use? So GGT, what we normally the enzyme, the gamma glutamyl transferase enzyme is the major indirect biomarker for ethanol use. So patients who have been chronic alcoholic, we always test for this GGT. Okay? These levels will be very high because it is stimulated to produce a metabolism of this alcohol. There is a chronic elevation of GTP, and AST and ALT are also elevated. And this ratio is used to identify chronic alcoholism. How is it used? What is the ratio?
more than AST ALT ratio
More
more than
than
2, sir.
2, sir. Alcoholic liver cirrhosis, if AST by ALT ratios be more than 2, sir. More than 2 to 4.
What is that ratio called? Is there any name for that LT to AST ratio? It's called de-Ritis ratio. DERITIS, de-Ritis ratio. Okay? It's the ratio between the ALT and AST. And the carbohydrate deficient transferrin, this is another indirect biomarker, and mean corpuscular volume will be also reduced because the RBCs start reducing or start rather enlarging, so they will something have a cirrhosis like picture. So these 4 are considered as indirect markers for chronic ethanol use. Actually, chronic ethanol use can be identified even if the patient lies, oh no, I don't drink that much. If all these values are elevated, that means patient is a chronic alcoholic. That can be confirmed by that. Many of you would have seen the policemen standing on the road in the night checking for drunken driving.
Yes, sir.
They ask the passenger to blow. How do they find out if there is alcohol consumption or not? How do this alcohol detection from the breath is done? What are the what thought about it?
Aldehyde conversion is there.
Aldehyde conversion. So when you blow, does it you blow aldehyde into that? Because ethanol is excreted directly from the lung without metabolization. That is why you get the smell also. Whenever you drink and you blow your out, you get the smell. Try to tell me the answer also. Just check about it. Right. What is the pathophysiology of alcoholic hepatitis and cirrhosis liver? This is a classical picture. So alcohol prime liver cells. So they stimulate the Kupffer cells. Activated Kupffer cells produce all the inflammatory cytokines, and then the some of them cause apoptosis, then some of them lead to Kupffer cell mediated phagocytosis. Then they stimulate the collagen formation. Hepatic stellate cells, these are the ones which are made to proliferate. They go on to produce the collagen type 1 and fibrosis. And that is also introduced by the chronic inflammatory nature of the TGF-B1, the most important inflammatory cytokine. And the steps in the alcoholic hepatitis are gut permeability increases, toxemia can occur, and first cell to be inflamed or activated is the Kupffer cells, as we all saw is the sinusoids. Once the alcohol gets absorbed from the gut into the bloodstream, goes to the sinusoids, activates the Kupffer cells, which produces the TNF alpha, which causes the inflammation. And once the alcohol is metabolized by the alcohol dehydrogenase and acetaldehyde is produced, acetaldehyde also stimulates the production of tumor necrosis factor alpha, which again also contributes to the inflammation. And acetaldehyde can combine with other chemicals to form adducts, which can directly damage the hepatocyte. And this third enzyme, which I told you in the first slide, CYP2E1, that will be activated, that can produce the oxygen stress, and they activate the stellate cells, which again directly produce hepatocyte injury, as well as the stellate cell proliferation leads to the fibrosis. And chronic alcoholics, they don't eat properly, so they go into malnutrition, and malnutrition prevents regeneration. Liver is one organ which can have enormous potential to regenerate however much it is damaged. Why? Compared to all other organs, liver cells can regenerate if you reduce the stress on them, the insult on them. For example, a chronic alcoholic, if he stops drinking for say 1 week, the liver will again start regenerating and try to get back its normal activity. How is it possible?
It has produced from unipotent cells.
Unipotent cells, very good. The stem cells from which the liver is produced is a unipotent stem cell. So it produces only liver cells. Whereas the blood products which you have, your neutrophil, your basophil, monophil, your macrophages, all these things are all from pluripotent cells. One stem cells giving rise to the various other divisions. So pluripotent cells will not have that much of regenerative capacity, whereas the liver cell, because it is produced from unipotent stem cell, has the enormous capacity to regenerate. So these are all the various stages of alcohol-induced liver damage. First inflammation, then hepatic injury, and third is the fibrosis. So this fibrosis is prevented from regenerating by impaired nutrition. This is how the whole process of chronic liver cirrhosis happens. Now, what is portal pressure gradient and what is the value of it? Portal pressure gradient.
Sir,
Hepatic artery pressure and
Yes,
portal.
It is the gradient between the portal vein and the hepatic vein. Okay, so the difference between the portal vein pressure and the hepatic vein, where ultimately this portal vein has to drain. Once the portal vein and the hepatic arterial blood, they mix and go to the sinusoid. Ultimately, we saw that sinusoidal blood goes and drains into the central vein, which ultimately goes and drains into the hepatic vein. And the hepatic vein will ultimately go drain into the inferior vena cava. So the pressure gradient or the difference between the portal venous pressure and the hepatic venous pressure is called the portal pressure gradient. What is the normal value for this?
1 to 5.
1 to 5 millimeters of mercury, normal range. And how does portal hypertension manifest at various values of this portal pressure gradient?
More than 25.
More than 10.
Portal pressure gradient in the range of 5 to 9 represents subclinical portal hypertension. Okay? Whereas more than 10 is a overt or established portal hypertension, where complications like bleeding, ulcers, or varicose esophageal varices, ascites, hepatic encephalopathy, renal failure, all can happen. So that is the importance of this gradient. Whenever the pressure goes up in the portal vein, it will start manifesting as the portal hypertension. And how ascites is formed in cirrhosis? What is the mechanism?
due to hypoalbuminemia, sir.
Hypoalbuminemia. Is that the
And
major?
the portal pressure leads to spastic vasodilation. That can cause ascites.
So it is theories are given. One is called the underfill theory, second is called the overflow theory, and the third is called the vasodilatation theory. Okay. So these three theories, how they act is cirrhosis produces portal hypertension, leads to ascites because of the oozing from the high pressure, decreased effective intravascular volume, leading to renal sodium retention to maintain that volume. Then primary renal sodium retention itself because of aldosterone production, increased blood volume. Then peripheral vasodilatation leading to decreased effective volume, and again mechanism to restore that is renal sodium retention. And all these things, and the blood volume increases and the pressure is high, it starts oozing from the communications inside the peritoneal cavity, the fluid starts accumulating. So it is actually seeping from the portal system because of the high pressure. Which are all the sites of portal and systemic circulation anastomosis?
Esophagus,
Esophageal varices,
retroperitoneal, sir, and umbilicus,
umbilicus, Three you have mentioned. Anything below large bowel, rectum?
Rectum, sir, rectum.
So sorry. So this is the lower is end of esophagus. This is very, very important because esophageal varices sometimes can bleed and that will become an emergency where the patient will come land up with a lot of hematemesis. And lower part of the rectum, they can have hemorrhoids and bleeding through that. Then paraumbilical region is called the caput medusae, can have retroperitoneal collection between colic vein and the posterior abdominal wall, and PDA intrahepatic portal system ductus venosus can happen. And so these are the important sites where the communications happen. Now coming to hepatic encephalopathy, which is a very common feature in acute liver failure. So few things about that. What are the etiologies of hepatic encephalopathy?
Liver failure, sir. High protein diet.
The root cause is liver failure. Also occur alone, that is mostly in acute liver failure, but most chronic liver failure patients, it causes because of excessive nitrogen load, protein rich diet, GI bleeding, renal failure, constipation, etc. Electrolyte disturbance, sedatives, alcohol, and bacterial peritonitis, etc. So these are all things which can precipitate. How is it treated?
Lactulose syrup. Neomycin and lactulose syrup.
So the lot of things you have to say. Not only neomycin, diet, reduce protein to minimum possible, and you can give lactulose to prevent the beta-glycoside dose, which is even doses of 45 ml. This thing, or as an enema in case patient is not able to take orally, and sodium benzoate, which eliminates ammonium hydrochloride probiotic, and ornithine aspartate and N-acetylcysteine. All these are diet. The antibiotic neomycin to prevent gut translocation of bacteria and produce sepsis. Metronidazole, rifaximin, and flumazenil to prevent the benzodiazepam-like receptors to prevent the hepatic stupor and coma, and bromocriptine is a dopamine receptor agonist to the conduction. So these are all the treatment that we have to give, and based on the occurrence of hepatic encephalopathy, how is the liver failure classified as? What is acute liver failure? What is chronic liver failure? What is acute on chronic liver failure?
Sir, within 7 days after this, sir, acute.
Hepatic encephalopathy occurs within 7 days of finding out jaundice or liver damage. It is called acute liver failure. 28 days is called chronic liver failure. I mean, acute on chronic, and 3 months it is called chronic liver failure. Okay? So in that way also hepatic encephalopathy helps in identifying the acute nature of liver disease. Now, what is the renal system effect on the liver disease? How is renal system affected?
Hepatorenal syndrome.
Hepatorenal syndrome. Yes, factors responsible for that are byssal, cytotoxins, etc. They produce increased nitric oxide, chronic vasodilatation, reduced effective circulating volume, leading to compensatory neurohumoral mechanism, decreased antidiuretic ADH hormone, decreased free water clearance, hyponatremia, and all these things increase renin, angiotensin, aldosterone, low urine sodium, sympathetic nervous system activation, renal vasoconstriction to cause decreased perfusion, all leading to condition called hepatorenal syndrome. What is the treatment for this?
Sir, Beta blockers.
Beta blocker.
Somatostatin, octreotide.
Terlipressin, which is used as
Terlipressin.
a this thing. So, but ultimately,
Renal transplant.
Liver transplant.
liver transplantation. Can a patient who has shown features of hepatorenal syndrome, if he dies, can the kidney be transplanted to a renal failure patient?
Yes, sir. Renal parenchyma will be normal only, sir.
Parenchymal damage is not there. So that
Yes.
kidney will definitely work in a patient who is having a normal liver. So that kidney is eligible for transplantation. Factors that can precipitate HRS are all bacterial infection, varicose bleeding, alcohol hepatitis, and large volume parasitic. This is one of the important things that you have to remember. Whenever, for any reason, you drain the ascitic fluid, then you have to expect patient to go in for renal problem. What are the biomarkers to detect whether there is a renal injury or not?
Creatinine.
Huh?
Creatinine, sir.
Creatinine is a very late sign. So interleukin 18, albumin, and urinary neutrophil gelatinase associated lipocalin. NGAL are the most validated biomarkers for renal injury in patients with cirrhosis. Okay. Your normal urea creatinine. How is the respiratory system affected in cirrhosis?
Hepatopulmonary syndrome and
Two
portopulmonary
things can happen. One is called hepatopulmonary syndrome, portopulmonary hypertension, hepatic hydrothorax. These are the three changes that can happen in cirrhosis patient. So, how is hepatopulmonary syndrome identified in early stages? When it happens.
Hypoxia. Respiratory, that increased work of breathing, sir. The patient.
Please work of breathing.
hypoxia.
The difference in oxygen saturation between supine and upright position using pulse oximetry is used in the initial stages. Okay, it's called the orthodeoxia.
Yes, sir.
Okay? That is the most important indicator of occurrence of hepatopulmonary syndrome. So, patient who has which kind of place you will have a better oxygenation. Lying down or supine?
Supine had a better oxygenation, sir, compared to upright position.
Upright position.
Yes.
So that
Supine
is
had
the
a better
difference.
oxygenation.
Okay, normally patients who are dyspneic, usually they feel better. Cardiac dyspnea, patients feel better because the venous drainage is reduced and the heart load is reduced. So patients, cardiac patients always used to sit up or lean forward. Whereas the hepatopulmonary syndrome patients, they find difficult to sit up. They find it comfortable to lie down. So the saturation will be better in supine position than in upright position. And which is the gold standard to confirm the presence of this hepatopulmonary syndrome?
Tran T is a
And
Using agitated
T.
saline during contrast has transthoracic echocardiography. That is the ultimate test which will confirm that. Which is the predictor of mortality after vessel transplantation patients with hepatopulmonary syndrome? One of the indicators for transplantation is the occurrence of hepatopulmonary syndrome, but beyond a particular level, even if you do liver transplant, patient may not survive.
Pulmonary artery
pulmonary
hypertension.
hypertension.
So,
More than
arterial oxygen tension is the most important predictor of post-transplantation mortality. So, saturation less than 44 millimeters is considered a very precarious condition. What is the ultimate treatment for HPS? It is the liver transplantation. What is the characteristic of hepatic hydrothorax? Which is one of the, again, a common complication of this. Is it an exudate or a transudate?
So either translate, sir.
The transudate pleural accumulation in a decompensated liver without underlying heart or lung disease. That is the beauty of this hepatic heterothorax with the transudate pleural accumulation. How is the risk stratification done? And how is it useful? So far we have seen all the pathological changes that happen in liver disease, especially cirrhosis in the various systems, which are the common questions that the examiners ask you. Now we have come to the level of identifying the risk involved in these patients based on these pathological changes. The oldest system that we use is the CTP scoring system, but before that it can be classified into cirrhosis related risk factors, surgery related risk factors, demographic comorbidities. So this is how the total overall risk classification can be done. But under the cirrhosis or liver disease related, you have the MELD score, CTP score, albumin as a marker, platelet count, ascites, encephalopathy, varices, portal pressure. The clinical manifestations are also taken into account for assessing the risk. And surgery, whether it is an emergent or elective, the type of surgery, complexity, how much duration the surgery is going to take, whether there is a need for intraoperative blood transfusion, and these factors also make a role in the risk. And patient's age, race, BMI, alcohol use, functional status, comorbidities like diabetes, sepsis, or congestive heart failure, all these things also add to the risk. But to assess the risk due to liver alone, we use commonly the CTP scoring system. And how is it assessed to assess the mean survival? All of you know about this: serum bilirubin, albumin, prothrombin time, encephalopathy, and ascites. These 5 parameters are given points, and the classes are A, B, C, and based on that, the survival. If in the class A, 1 year survival is 100%, 2 year survival 85%. It goes to C, which is the most dangerous or most worst prognosis. The 1 year survival itself is 45% and 2 year survival is only 35%. What is the reason for developing MELD scoring system? And there was a CTP scoring system.
Survival after end stage of liver
One is
disease,
survival as well as to decide
liver
the
transplantation. Patient is for
priority for liver transplantation. Because once the patient is diagnosed with end stage liver disease, you must be able to identify the person who will be benefited by doing the transplant, not by doing transplant in all patients. Because as I said, if the hepatopulmonary syndrome is very bad and oxygen saturation is chronically less than 40, that patient even after transplant may not survive. So to identify the patients who have a better prognosis after transplantation, MELD scoring was introduced. Okay? So risk assessment tools for mean survival as well as for priority for liver transplant. And how is it calculated? And what predictions are made using this score? It's calculated by this formula. Only 3 things are taken into account. One is the serum bilirubin, second is the INR, third is the serum creatinine. Unlike your CTP score, where you take encephalopathy, ascites, all that is not taken into account. Even albumin is not taken into account. So you are taking these 3 parameters. Using this formula, you can 0 to 39. So you have 4 classes. Like the CTP, where you have only 3 A, B, C. Here you have 0 to 9, 10 to 19, 20 to 29, and 30 to 39. And predicted survival, very good in the low scores. Higher score, it gradually goes down. And what is ALB score?
albumin and bilirubin score. It is the
Albumin
early
and
stage of
bilirubin.
detection of.
So from the 3 parameters or the values, you reduce the scoring system to only 2 using the albumin and bilirubin. It scales two objective laboratory values, and it detects early deterioration of liver function. It is not a scoring system to find the advanced cancers. It's used even during the early stages of liver damage. And the formula that we use is log 10 bilirubin multiplied by 0.66 albumin gram per liter multiplied by 0.852. This is the formula that should be used. And you have three grades, grade 1, grade 2, and grade 3, where the values will be like this. And lastly, you have adopt LC score. It's called adequate operative treatment in liver cirrhosis, but not very commonly used. You just know the name, you remember that. And what investigations are needed in patients with liver disorders? What are the important investigations you should carry out?
Complete blood count,
LF, liver function test,
coagulation
coagulation
Complete
profile,
blood count to rule out anemia or infection, right? Then
coagulation profile like PT, INR,
PPINR, indicator of severity and prognosis. Then
liver
Sir,
function
RF.
test, albumin,
platelet count assay and thromboelastogram. Find the
Renal function.
coagulability. LFT, mainly albumin and enzymes and bilirubin.
electrolytes,
Then RFT, indicator of volume status and hepatorenal syndrome. Electrolytes,
yeah.
actually you have hyponatremia, hypopotassiemia, and hypomagnesemia may be there. Ultrasound abdomen, to find out the degree of ascites, liver and spleen enlargement can be found out. Then you have modern investigation called fibroscan to assess the stage of cirrhosis by the texture of the liver. And you have EKG X-ray test for cardiomyopathy and pleural effusion. And how to optimize the patients with liver disease. Control the treatment that you should do. First and foremost in this is free. Alcoholic liver cirrhosis, abstain from alcohol. Okay? Nutrition assessed by lean body mass, urine albumin, triceps in fold and circumference. Hypoglycemia is likely due to diminished hepatic glycogen. Okay? So that should be corrected. Hyponatremia is very common, causes excess free water. Treat with aldosterone antagonist and low salt diet, and correct potassium level. Watch out for early signs of encephalopathy. Oxygen saturation, room air, cases of HPS and portopulmonary hypertension. Paracentesis to improve oxygenation and prevent aspiration. More than 4 liters is tapped. Give albumin transfusion. Or you can introduce what is called the leave-in shunt, which was used. Now it's not quickly done. And correction of coagulopathy by checking the platelet, fibrinogen, peg, and vitamin K, IM, IV for 3 days before the major surgery. Keep ready FFP cryoplatelet as per the peg value. Prevent infection and sepsis. And there is something called TIPS, transtubular intrahepatic portosystemic shunt, to reduce the portal hypertension. The cases of refractory ascites and decreased renal function, this is indicated. And to remove the toxins, just like the dialysis for kidney, we have another mechanism called MARS, molecular gluten recirculatory system, where toxins and drug overdosage can be removed. And what are the goals in the anesthetic management, which things you can know, right? First and foremost goal is preserve hepatic blood flow at any cost. There should not be undue prolonged hypotension or hypovolemia. Factors which decrease hepatic blood flow are mechanical ventilation and heat, hypocapnia, hypotension, and stress of surgery. All these things will decrease the hepatic blood flow. Monitor and maintain renal function throughout the surgical procedure. Prevent CNS depression and encephalopathy. And prevent coagulation failure by fixing the TEG and the value, and corrective measures have to be kept ready. Maintain normoglycemia, don't allow hypoglycemia to creep in, preserve electrolyte balance. And the choice of anesthesia for this particular surgery. Whenever a surgical condition is also indicated or given in the case scenario, your description of anesthesia should pertain particularly to that particular surgery. Okay, there is no point in describing all the techniques that you know, and it must have some relevance to the surgical procedure that is being given in the case scenario. So if it is a small reducible hernia, minimal or no ascites can be done with local infiltration or bilateral recursive block in any class of CTP score system, whether it is A, B, or C. All these patients will withstand this technique of anesthesia by local infiltration or bilateral recursive block, or a very small hernia I showed you in the initial picture that can be done. If it is a moderate sized hernia with bowel or omentum as a content, then you can think of central neuraxial blockade, epidural or combined spinal epidural, provided coagulation profile is normal. Then the third option, huge hernia requiring extensive dissection and repair, better go for GA. And laparoscopic repair, GA after paracentesis to remove the ascitic fluid. So that option also has to be included in your answer. And with regard to GA, if they ask you about the detail, then you say main thing is to avoid all drugs which will cause an acute liver failure by decreasing the hepatic flow or depressing the existing function of the liver. So all opioids and all depressant drugs to be used in caution. And the pharmacokinetics and pharmacodynamics are completely altered in extreme cases of liver failure. So drugs have to be used very carefully, especially sedatives have to be used in a very cautious manner. And drugs which are purely eliminated by liver or metabolized in the liver are preferably avoided. So drugs like propofol can be used for induction. And the common question they will ask you, why propofol for liver disease?
It metabolized by extra hepatic
It increase
also,
the
and
hepatic
preserves
Other than
it
the
preserves
liver,
hepatic
there
blood
are
flow.
sites where extra hepatic metabolism can happen and the elimination can happen. That is why propofol is considered as a drug of choice even for liver transplantation patients. And which is the drug of choice? Relaxant.
Isoflurane.
Relaxant, not inhalation.
Atracurium.
Atracurium or atracurium are the drugs because they don't depend on liver or kidney for elimination. And the inhalation agent of choice is isoflurane. Why? Again, that question, why?
0.2% metabolic metabolism.
Metabolized, but also another important point is it is supposed to preserve the HABR, hepatic arterial buffer response,
more
is
than
better preferred by isoflurane compared to the other agents like CO or fluorine. And analgesia of choice, intraoperative analgesia. Paracetamol, if you are routinely using, can you use that for liver disease patient?
I'll give reduced dose of 3 grams, sir.
Reduce dose. Avoid narcotics as much as possible, or use short-acting agents like remifentanil, or moderate or restricted doses of fentanyl can be used. Rely more on facial plane blocks or other regional techniques, but keep a watch on. When you rely on regional techniques, what is the precaution to be taken? Total dose of local anesthetic, because all the local anesthetics are metabolized, especially amide local anesthetics are metabolized only in the liver. So you have to keep a watch on the total dose and calculate, especially when you want to give bilateral tab block or recursive block, you must have a eye on the total dose that you are using. Okay. These are all the points that you have to keep in your mind when discussing for liver disease patient, whether it is for short case or a long case.
Yes, sir.
From there. Or any questions or any doubts on that?